Thank you. So yes, when we talk about pediatric depression and anxiety, and it's the question of, what's new, unfortunately, I would argue not a lot is new. We certainly don't have any new novel treatments or anything, but I think what's new is this growing understanding of the needs, of the morbidity that's associated with pediatric anxiety and depression, the lack of child psychiatrists in the nation, and other mental health care providers, and just kind of the growing need of all medical providers to be more aware of pediatric depression and anxiety and how to treat it. So I have no financial interest in anything, and I certainly will be discussing many off-label uses of antidepressants in kids, because most of them are off-label. But what I wanted to do today was just kind of this really brief overview of what pediatric depression and anxiety is, what it looks like, how you recognize it, talk about what the current clinical guidelines are for treatment, and then specifically some nuts and bolts of SSRIs. So obviously both anxiety and depression are very common in kids, and again I think there's this growing recognition of this. Anxiety disorders are the most common psychopathology in youth. So studies vary kind of depending on some definitions, but the generally accepted prevalence rates is around 20% for an anxiety disorder in kids, and these are with specific phobias most common, and then kind of down that list. Girls are more likely to have an anxiety disorder than boys. The average age of onset for anxiety disorders is really hard to say, probably because we just kind of get anxious traits throughout our lifetime. And so you get the story of, hey, this was the really kind of fussy baby who never settled down, who didn't sleep well, and then we go along and then maybe had huge separation when they're going off to preschool or kindergarten, and maybe developed some obsessive compulsive traits in grade school, but it's just kind of this lifetime course. Depression also very common, although with depression it's interesting, there's this clear distinction after puberty, after kids hit puberty. And so after puberty it becomes much more common. Before puberty you get kind of female-male ratios fairly equal, versus after puberty it's definitely predominantly female. One of the interesting things is, again, even though we are recognizing it's common, it's still commonly undiagnosed. And so studies of adults have looked back and said, yes, they clearly met criteria for depression during adolescence, but only about half of the time was that recognized. And I think another really important part to bring up when we're talking about this prevalence is all these rates of 20% for anxiety and maybe 10, 15% for depression. These are general population bases, and if you just look at the prevalence of who's walking into a doctor's office, those prevalence rates are higher. So those are estimated to be somewhere around 25% for depression and close to 30 or 40% for anxiety. So what are the risk factors for depression and anxiety? Well, clearly there's a genetic component to things, family history, what we're getting through the genes. Interestingly enough, there seems to be more genetic component to depressive illnesses than anxiety illnesses. And so like if you look at adoption studies, you take a child whose biological parents had depression, put them in a home where there's no depression, there's still much higher risk to develop depression. Versus anxiety, there also seems to be a huge environmental component. And so you take adopted kids who biologically don't have any predisposition for anxiety, but they're adopted into an anxious household, they are more likely to develop anxiety. And so again, with anxiety, huge role of kind of the parental anxiety, parenting styles, attachment and temperament plays a big role. Clearly other psychiatric disorders are comorbidities, so that's kind of the rule in psychiatry. If you have one diagnosis, you likely have many. And obviously trauma and other psychosocial stressors are risk factors for depression and anxiety. And as was mentioned, one of the areas I really work in is with kids with chronic medical illness who have much higher rates of anxiety, depression as well. Depression obviously comes with significant morbidity. It's estimated that somewhere between a third to a half of depressed youth with depression will attempt suicide. And over the course of a decade, somewhere between 2 to 8% of depressed youth will complete suicide. You always look at the CDC numbers that come out all the time, and there's definitely, right below motor vehicle accidents, source of morbidity in adolescence is suicide. Also, significant mortality comes with anxiety, depression. So these kids are, more likely to underachieve educationally, get into trouble with the law, substance abuse, unwanted pregnancies, these sorts of things. They then have higher rates of depression and anxiety as adults. And even if they don't end up having major depressive disorder or generalized anxiety disorder as adults, they still tend to have poorer functioning into adulthood. So how does anxiety and depression present? I'm not going to go through DSM-4 diagnoses. And DSM-5, which is due out any moment, there are no significant changes with anxiety and depression. But I think a couple points that are important to know. When we talk about children in particular, so younger school-age children, the most common way that they're going to present with depression or anxiety is these somatic complaints. These are these kids that are coming into the office complaining of headaches, stomach aches, don't want to go to school. That's the most common way anxiety depression is going to present. In adolescence, I think the importance of irritability cannot be understated. The majority of depressed teenagers don't have a depressed mood, they have an irritable mood. They're grouchy, angry, going off on everyone. And that's, again, a very common presentation for depression and even anxiety at times. How do you assess for depression? Again, obviously, there's no lab test, there's no imaging. The diagnosis, like many things in medicine, it's a clinical diagnosis. So if you're meeting the criteria, that's laid out in soon-to-be DSM-5. There are a handful of fantastic standardized assessment tools out there, and certainly if anyone's interested, I can direct you to them more specifically. But assessments tools are great for screening for depression, anxiety, or following treatment, so we get a little objective measure of kind of how well is our treatment working. And then, of course, when we're assessing for anxiety and depression, it's important to assess for other comorbid diagnoses as well. Differential, again, the other psychiatric disorders, often anxiety and depression can look so much alike, and they often are both there. The convenient thing is you treat them both the same, so it's not that big of a deal if you can't clearly distinguish the two, versus something like, obviously, it becomes very important to distinguish unipolar depression from a bipolar illness. There are medical disorders that certainly can mimic symptoms of depression and anxiety, although, again, fairly uncommon in young ages, and medications as well. So if we know it's out there and we're able to recognize it, how do we treat it? Well, certainly when we look at treatment in general, we're going to be talking about therapy plus or minus medications. And again, there's no great new novel stuff that's come out, but we are getting more evidence to suggest that the things that we've been doing empirically actually have some evidence behind them. So this is the only slide I have on therapy, which probably doesn't really do it justice, because therapy truly is the mainstay of treatment for adolescent depression and anxiety. I'll talk a lot about cognitive behavioral therapy because that's the sort of therapy that's most studied. It's a manualized based, you have these books, manualized based therapy, so it's very conducive to studying. And what cognitive behavioral therapy involves is cognitions, the cognitive parts, your thoughts and kind of the distorted thought patterns that start and how to restructure those, as well as the behaviors that influence your feelings and emotions, and so how to be changing those. So it often involves a lot of psychoeducation, a lot of skills training, perhaps exposure therapy if we're talking anxiety, scheduling of pleasurable activities and depression, these sorts of things. There are plenty of other therapies out there. I mean, I list a few: interpersonal, psychodynamic, supportive work. These are therapies that I think as clinicians we know absolutely work and benefit, although there's not great evidence to support them. And then I specifically at the bottom mentioned parent and child work, because when we're talking especially anxiety disorders or especially younger children, obviously the involvement of the parents and families becomes crucial. So moving on to medications, again, SSRIs are definitely the medication of choice. And beyond that, we really have very limited evidence talking about what's new, there was an article that came out in Pediatrics this month that was looking at all the current FDA trials of neuropsychiatric drugs, and only 10% of those trials were on anyone under the age of 18. And so as you looked at all the neuropsych drugs out there being studied, only, I think it was like 18% of them were had any sort of study connected to children, and the majority of those were in ADHD, and so it was even less than 8% that were any sort of antidepressant or antipsychotic medication that were being studied. This is, to my knowledge, as I try to collect the data, this is the trials that are out there, the short, brief, placebo-controlled randomized trials for an anxiety disorder in youth. So as you can see, not huge numbers out there by any stretch of the imagination. And so there is no medication for anxiety disorders, excuse me, in kids that has FDA approval. Now, obsessive compulsive disorder, which is kind of broad anxiety disorder, there are both fluoxetine and sertraline are FDA approved for obsessive compulsive disorder. But otherwise, if you're talking generalized anxiety, separation, social phobia, none of these have FDA approval because there's not really robust evidence. That being said, there certainly is suggestions that they are helpful in certain cases. Depression trials, not a whole lot difference to, again, not a whole lot of studies out there, but the bolded medications, fluoxetine and escitalopram, which is Lexapro, do have FDA approval for the treatment of depression. For fluoxetine, it's age 8 and up, and Lexapro is 12 and up. I don't want to bore people with studies, certainly, but I believe there are kind of 3 crucial studies in child psychiatry that I get on my soapbox. I feel like every pediatric resident and basically every primary care provider should be aware of. One of these is the Child and Adolescent Anxiety Multimodal Study. So this was an NIMH-sponsored randomized controlled trial, 12 weeks of just under 500 kids with separation, generalized anxiety disorder, or social phobia. And they randomized them into 4 groups. So you had a group that got cognitive behavioral therapy and sertraline, a group that just got sertraline, a group that just got cognitive behavioral therapy, and then a group that just got a placebo pill. And at the end of these 12 weeks, they found that any of the groups getting treatment improved significantly, statistically significant, over the group that just got a placebo pill. Although it's interesting to note, and there was no huge statistical significance between these 3 groups other than cognitive behavioral therapy and sertraline was clearly more effective than sertraline alone. So what does this tell us? It tells us a number of things. One, the importance of therapy in treating anxiety disorders is crucial. There's hints that adding medication may help kids resolve their anxiety symptoms quicker. The other interesting thing was that the group that got cognitive behavioral therapy and sertraline, as compared to sertraline alone, had a lot fewer side effects from their medications. So somehow being in therapy is protective from having too many side effects from your medication. The next study I want to mention is a very similar one, but for anxiety. So this is the treatment of adolescent depression study. Again, this randomized controlled 12-week trial of adolescents with depression. Once again, these 4 groups of cognitive behavioral therapy and fluoxetine, fluoxetine alone, cognitive behavioral therapy alone, and placebo alone. And a similar response that combination treatment came out on top. Although it was not statistically significant difference than just the fluoxetine alone. So if you notice this, compared to the anxiety trial, these groups flipped a little. Perhaps suggestive that medication becomes a little more important in depression than it is in anxiety. And then interestingly enough, this study, after they did the randomized part for 12 weeks, they then opened it and carried it on observationally to 36 weeks and found that at the end of 36 weeks, all these groups were doing just as well. So again, suggesting that probably all these treatments are effective, but adding medication may help you get a quicker response time. The other things they found is they've kind of parsed this study apart even more, is that the more severely the depressed kids were, the more effect that they saw, or the more benefit they saw from medication. Also kind of piecing apart, trying to figure out, well, who was most helped by therapy or therapy alone. The higher the socioeconomic status of the family, the more that therapy seemed to help. And once again, they found that being in therapy helps reduce your side effects and adverse effects of medication. Last study, I promise. This is what's called the treatment of resistant depression in adolescent study. So once again, they took these kids with major depressive disorder, this time after they had been on a 2-month trial of an SSRI and felt like they didn't respond to it. And then they randomized them into switching to a different SSRI and adding cognitive behavioral therapy, switching to venlafaxine, an SNRI, so including norepinephrine in there, or switching to venlafaxine and CBT. And they found that adding CBT, so whichever drug you switched to, if you added CBT along with that, you had much better results than just switching to a different medication. And it really didn't seem to matter whether you switched them to an SSRI or you switched them to venlafaxine. They both improved. However, venlafaxine had a few more side effects than the group that just got the fluoxetine. So, bottom line from this, anxiety treatment, really therapy is gold standard. Especially in younger children or more mild anxiety, therapy alone, certainly involving the parent, would be the gold standard. In older children or the more severe anxiety, therapy again, absolutely, but consider adding an SSRI seems certainly appropriate, and there is something about that combination that seems optimal. In depression, the guidelines really seem to suggest, hey, if it's mild depression, or if we're talking really young kids, therapy alone. And there's even this idea of active support. So there's some guidelines that come out specifically for the treatment of adolescent depression in the primary care setting. And they advocate for this idea of active support. That, hey, if you're diagnosing a kid with mild anxiety or mild depression in your office, it's reasonable to say, hey, let's provide some psychoeducation. Let's talk about sleep, diet, exercise. See them back on a weekly basis for, quick 15, 20-minute visit on a weekly basis for 4 to 5 weeks. And usually their depression is going to improve and resolve just from that active support. Certainly in cases of more moderate to severe depression, this is where cognitive behavioral therapy and an SSRI are the gold standard. And in resistant depression, we know that, hey, it's worth switching to a different SSRI and obviously adding therapy if we're not already doing it. So just wanted to kind of then talk about kind of the specifics, some more specifics of antidepressants and probably SSRIs in particular. Obviously, side effects are common, and you guys know this, the GI stuff, the appetite, the sexual dysfunction, hopefully not as much of a problem in kids, but you never know. One of the newer things that's come out is the warning about prolonged QT intervals on citalopram or Celexa. And then we talk about more adverse events in particular. And there's this whole idea of suicidality, which I'll talk more about. But the studies seem to suggest about 2% of youth on an antidepressant have some increase in self-harm thoughts during the first 4 weeks of treatment. Kids can get activated. So again, somewhere 3 to 10% of kids will get more restless, more irritable, more agitated on an antidepressant. Obviously, there's always the concern of switching to mania, obviously discontinuation stuff, and the rare risk for serotonin syndrome. So where does this whole suicidality stuff come from? 2004, the FDA came out with a black box warning about the increased risk of suicidality in pediatric patients. And several years later, they actually extended it to young adults, so it's now a black box warning for individuals up to age 25. Where they came with this is they analyzed all the short-term randomized controlled trials and found that, 4% of kids taking an antidepressant spontaneously reported suicidal thinking during these studies, and only 2% of the kids on placebo reported that. Now, the challenges with this, and a lot of the critics of this have come back and said, well, but none of these studies were designed to look at suicidality. They were just designed to look at, is the depression improving or not? So you're looking at a secondary or tertiary outcome. Certainly no suicides occurred during any of these studies. So hard to know. There's people that have looked at it from a toxicology standpoint and have done these assessments, after suicide, and have found that, wow, even if we're prescribing antidepressants to these people, doesn't necessarily mean that it's in their blood at the time that they suicided, so maybe not quite as causal as people may have thought. And there's certainly plenty of epidemiological studies as well to say that, hey, where SSRI rates have increased, we've seen decreases in youth suicide rates, and vice versa. So one of my favorite visuals on this is just, these are SSI prescription rates in the US, and 2004 is right at the time of the black box warning, and you instantly see this decrease in all age groups, except the elderly, but certainly this dramatic decrease in youth age groups. And sure enough, if you look at the CDC rate on suicide, at the same time, there's this increased spike in suicides. Now, again, clearly it's epidemiological data, so not precise, but it does lend to the confusion. So bottom line, what do we know? Well, in anxiety disorders and antidepressants, there is obviously less of that risk of suicidality, so less of the risk of some of the adverse events, but anxious kids have more side effects from their medication. In moderate to severe depression, I think it's clear that the benefits of antidepressant definitely outweigh any risks, whereas in more mild depression or mild anxiety or these younger age groups, the benefit-risk ratio is a little harder to tease out. And certainly there's a need to not start any medication in a vacuum, but be monitoring it. So if you want to start an SSRI, which one do you choose? Well, the guidelines will suggest picking between fluoxetine, sertraline, citalopram, or escitalopram. They all seem to be equally effective as far as we can tell in the treatment of depression and anxiety in youth. You'll notice that Paxil or paroxetine is kept off that first-line list of SSRIs in kids, and that's simply because Paxil does have more side effects in kids and adolescents. But picking one of those, fluoxetine, sertraline, citalopram, or escitalopram, and picking it based on side effect profile, drug-drug interaction. If mom's done great on fluoxetine and loves it, I'm going to start Tommy on it. If you don't tolerate the first SSRI that you get, or it's not effective, the next step is to try a different one. Again, pick one of those others to try. And then really after 2 failed SSRIs, then it's reasonable to then try something else, an alternative antidepressant or anxiolytic. Of these, really, venlafaxine is the only one that's been studied and shown to have some efficacy in depression. All of these others, yeah, we have evidence in adults, but we don't have evidence that they're effective in children. And in fact, with benzodiazepines, we actually have some evidence to suggest they're not helpful in the treatment of anxiety in kids. This is just a brief SSRI comparison chart that I like, and I like to give to the residents to help them kind of see what some of these differences are. One major thing I point out is that fluoxetine has a much longer half-life than the others. This is problematic in the elderly, perhaps, but wow, a huge advantage in teenagers that may forget to take their medications now and then. Starting dosages, you increase them over weekly basis to get to kind of your expected effective dose, and then you still can continue to push them up to the maximum dose. I think often one of the things that I see when patients are referred to me and they've been following a primary care doctor is we haven't given an SSRI an adequate trial. So we've done kind of low dosages, and then it didn't work, and we switched to something else, and we haven't truly given them fair trials. The 40 milligrams of citalopram I just bolded because, again, that's a newer thing because of the QT interval. We used to push dosages up to 60 or 80 milligrams, and now the recommendation is 40s max. So you start an SSRI, you're going to titrate it to effective dose. You got to wait. These things take 4 to 6 weeks to build up blood levels, so you got to be patient. You got to give it some time. If there's no improvement at all, and we're going up on those dosages, again, we're going to consider a different SSRI, adding therapy. If there's partial improvement, we can keep maximizing the dose, add therapy if it's not always there. We can consider some augmentation. And then once we've had success, after symptoms have resolved, studies seem to suggest that we should then keep kids on an SSRI for at least 6 to 12 months after resolution of their symptoms. and then try coming off it. That helps decrease our relapse rates. So take-home points, anxiety, depression are both very common in pediatric populations. I'm sure you're well aware of that. Again, they often present with kind of these somatic symptoms or this irritability. Therapy and SSRI are the most effective treatments, and the benefits of antidepressants clearly outweigh the risks in more severe disease and in older ages. These are great resources to know. This GLAD PC, this is the Guidelines for Adolescent Depression in Primary Care setting, and they have this great website where they have all sorts of the screening tools for depression that are available in the public domain, and ideas for how to do cognitive behavioral therapy in your practice as a primary care physician with 10 minutes. The ACAP, American Academy of Child and Adolescent Psychiatry, has great handouts for parents and families talking about what is depression, what is anxiety, and then AAP also has excellent mental health documents. So, thank you.
I have a question.
Yeah.
We get called to the ER and a child has taken an overdose of some pills. They're in the ICU. They get they come out. They're okay. They get one psych visit. They're home, and it takes 6 to 8 weeks for the medicine to work. Meanwhile, the parents are concerned they're going to do something else. I mean, this is a real big issue for adolescents, and I don't know where to go other than just reassure, reassure, reassure. We don't have the greatest, outpatient therapy here, and it takes 6 to 8 weeks, and they're still in that critical time.
Yeah. No, it absolutely is a huge, huge problem, just access to care in general, and that. So recommendations, again, in an ideal world, you'd have access to therapy right away, right? You'd be able to get into therapy and access that.
Yeah.
In the absence of that, again, I think there's a lot that a primary care physician can do in terms of just this active support. There's something just about regularly scheduling visits, just seeing a patient, offering some reassurance. There's some really basic cognitive behavioral therapy strategies that can recommend, and these are things like scheduling pleasurable activities, writing in your journal, making sure sleep's okay, making sure these things are okay to try and get us through that bridge.
In adults, we sometimes use like an atypical to make it a little more faster. Can you do that in children, like a little Zyprexa or something?
So we certainly do. There's absolutely no evidence for it, but again, because there is evidence that antipsychotics can be helpful augmenting treatment of depression in adults, yes, if we're really severely depressed and want to do something like that, augmenting with an atypical antipsychotic is not unreasonable.
One more question. Does drug use affect how they respond to antidepressants if they're using marijuana or pot or anything like that?
Great question. Probably. Again, we don't have studies to show, and certainly, the majority of these meds don't specifically compete with cannabis or some of these others, but clearly it's going to be playing a role, and substance abuse is a really problematic comorbidity in this population. So,
could you say a few words about handling depression associated with anti-epileptic medications?
Absolutely, yes. This is what I do on a daily basis, sort of thing, because I do treat kids with chronic medical illness, and so a lot of epilepsy kids. But yes, so kids that have epilepsy, have seizures, certainly have much higher rates of depression than someone that's otherwise healthy. So the seizures in themselves can cause depression. And then you've got the anti-epileptic medications that may contribute to mood and that. And so the first thing I'll usually do is coordinate with my neurology colleagues in terms of, is this the best seizure med for them to be on from both the seizure standpoint and a mood standpoint? So like Keppra, for example, is notorious for increasing irritability in youth. And so, we'll have discussions with neurologists. Wow, could we get them on something else that would work just as well for their seizures or that? But I think kind of coordinating that. And otherwise, once we've kind of got the best we can do with anti-epileptic medication, then the best we have is just the same stuff, using SSRIs, using other medications to treat their depression. If that answered your question. So, thank you.